Hello everyone, this is Chadi Alraies from CVI 2022 in Colorado. I'm really privileged today to be with Dr. Marvin Eng. He's a medical director of the Structural Heart Disease Program at Banner Health in Arizona. Marvin, always nice to see you.
Thanks. Appreciate you having me here, Chadi.
Sure. So you are presenting a couple of cases where one of them is very complex, and I don't think everybody does it in their labs, is about valve-in-valve in the mitral, but for an annulus that is calcified and need fracture. Can you fill us on up?
Yeah, so it turns out that when you look at valve-in-valve in the large series, there's a paper that Wisnet published in JAMA Cardiology, and you see that people with small valves, when you do valve-in-valve with them, they have higher gradients, and this is reproducible across a lot of registries, but at their 1 year survival was attenuated, and no one really knows why, but we hypothesize it may be related to the higher valve gradients. And because we've seen this problem, we hypothesized that we could extrapolate our experience from the aortic valve and valve fracture in the valve to the mitral position. It's different because the valve is sewn into the EV groove. We don't really know what the tolerance for a high pressure inflation would be like. But after seeing some negative impacts of leaving a patient with a high gradient behind, we decided to go forward, and we fractured this. In this case, it was a Medtronic porcine valve. It was,
It was degenerated and mitral regurgitation wide open.
So it had mixed regurgitation stenosis, mostly stenosis, and we did a high pressure inflation to fracture the annulus ring, and then implanted a larger valve, so avoiding a 23 millimeter valve, but using a 26 valve instead.
Wow.
And then expanding that valve, and that patient was left with an acceptable 3 millimeter invasive gradient.
Yeah.
So we've done this for a few cases, and there's a lot to be learned because, as you might suspect, not every valve fracture is the same. Some people have recoil, so there's a lot that needs work that needs to be done, just like it was done for the aortic space, but for the mitral space. Yeah. And of course, there probably needs to be better platforms for valve-in-valve to mitigate things like LVOT obstruction, and so that people can have the largest valve possible or largest effective orifice area possible after a valve implant.
Absolutely. So I'm assuming these cases require a lot of planning ahead of time. So if you can walk us through CT, 3D printing, what have you done?
So it's mostly CT and echocardiographic pre-planning. The CT is important for, and of course the op report, so the history, right? So you need to know the valve size, the model, all that stuff. And even though it sounds easy, it's harder to come by than you imagine sometimes. And then the CT is really important for understanding and modeling the neo LVOT. Will there have to be a modification made? You have to understand the difference between porcine valves and pericardial valves. Pericardial valves, the leaflets tend to go all the way up to the top of the posts, but the porcine valves, usually it stops maybe half or 2/3 of the way up. So the risk of LVOT obstruction is a little bit less.
Yes, yeah.
You have to, get a sense for, is there a lot of calcium around the valve? Is there MAC that you're concerned about that may cause a perforation later on? So
this is predictable in terms of calcification causing perf?
Well, that's the thing, is it's not. But it goes into your calculus, what kind of risks are you willing to take? So like I was saying, there's a lot to be learned still about what kind of limits you can push. And there just may be some patients that are not good valve-in-valve candidates, and maybe they have to have surgery. But some of these patients we've seen have had 2 or 3 sternotomies already.
Yeah. And when you have, do you think, again, I'm not a structural interventionist, valve-in-valve are more forgiving than valve-in-MAC in terms of calcification burden?
Well, we don't really know about that. So what we can say is there's not a lot of people who already have MAC who get valve surgery already, okay? So the people that do have that and they acquire it later on, that's a little, that's unusual, and we don't see a lot of those patients. We do know that if you look at valve-in-valve outcomes, and you compare it to valve-in-MAC outcomes, they're far superior. So you compare valve-in-valve to valve-in-ring or valve-in-MAC, they have the best short and long-term prognosis post-procedure. So we would like to think that if we can give these people acceptable gradients and no LVOT obstruction, that they will do pretty well.
Sorry, yeah?
Yeah.
Well, that's wonderful. Thanks so much for explaining to us this complex cases. Please watch these videos and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Marvin, thank you so much.